Are your testosterone labs flawed? Are they messed up? We want to understand the science, incredible technological science of testosterone labs for diagnosis and management for men on testosterone. This is an interview with a patient of mine, Shimon Lobel. Welcome, Shimon.
Hi.
And happy birthday, sir.
Thank you.
So I'm going to tell you guys how this came to be, and then we're going to let Shimon run this thing. So he's a patient, and thank you for allowing me to say that, sir. He's a 45-year-old guy. Happy birthday today.
Thank you.
So he's a healthy man with the grace of God. And when I ask my patients for labs, my nurse sometimes has to hound the guys. Hey, Frank, we need the labs. Get the lab. Here's the labs. Can you go for the labs? This guy never, ever, ever fails to deliver. Matter of fact, he over-delivers, because when I ask him for labs, he recently gave me like 3 labs for testosterone with different technological LS, the liquid chromatography. And I was like, whoa, and they're all over the board. So when you look at testosterone, total and free, there's different methodologies. We're going to go into today. It's so important. Your doctor, your nurse practitioner, you as a man and a woman, of course, are looking at this number on paper. There's so much variability. We have to really get into the science of this.
I'm Dr. Thomas O'Connor, a lifelong powerlifter, board-certified physician, and published academic author. I've taken care of thousands of men on testosterone and steroids, and now I use my media appearances in this YouTube channel to provide education and harm reduction. Subscribe now so I can help you stay strong and healthy.
Shimon, tell us first off how this story came to be.
So when I started being your patient, you told me go to the lab and get tested for testosterone LCMS. And me working at Accureference Medical Lab, I went to the lab and I got my labs drawn and sent over the labs to your office, and I had my consultation. And you right away said, something's off over here. The free testosterone just does not make sense. So having access to different lab tests and different methodologies, and even to work with other laboratories and to send them to correlate on my results, I sent my labs out to other laboratories that are running testosterone free and total LCMS. And it turned out that the results at my lab were inaccurate.
Wow. So guys, the basis of this video education is that if you're looking at the numbers and they're all over the board, this is a big problem. When a doctor just looks at a total testosterone, this is like cringy, right? I thought like years ago this would be cleared up. It's still happening today. Sex hormone binding globulin, total free. Is it nadir? Is it peak? I mean, are you on propionate, cypionate, enanthate, undecanate? Oh my God, this is just... So let's anchor in to the science of testosterone from a technological standpoint. Tell us clinically, what's going on here?
So LCMS is the gold standard for Dr. O'Connor and for endocrinologists, urologists. That's the gold standard to anybody who is on testosterone, and they should be testing right before their injection. So if they're injecting in the morning, that morning, go to the lab and get yourself tested. And the results will be different if you go 2 days or 1 day prior. You'll see a higher result, and on my last labs, that's what that was. I just was testing myself, just again, testing our system to make sure our labs, I was testing on myself. And what I do at the lab is that I push the department manager on any time that the results are a little bit, don't seem 100% right or doesn't make sense. So I always test myself, and just to make sure that the results are accurate. And at the same time, I always confirm it with an outside laboratory to make sure that everything is 100%. Because I'll give an example with what we found is with our free testosterone, after the labs being drawn, and patients don't see this on the back end, is that the specimen is frozen. And then after it's frozen, it's transported to the laboratory where it is processed and then goes back to another freezer. And then sometimes what we found in our methodology was when the specimen was being defrosted and then ran on the specimen, what we found is that the testosterone, the total testosterone was being separated from the sex-binding hormone globulin, therefore raising the free testosterone levels higher than what it really was.
Wow.
And therefore I said, and Dr. O'Connor right away picked up on this immediately when you saw that my free testosterone was off. It was double what it really needed to be. And I went to the lab director and he right away said, yeah, this is a problem. And we've put processes in place to make sure that this doesn't happen again. Because just also a little bit more technical is that the most of these LCMS methodologies, if not all of them, they're not FDA approved tests. So it's a lab developed test, which is approved by oftentimes the state Department of Health of different states and has to be submitted. But it is a methodology that's accepted, but it's not something that the manufacturer constantly reproduces. It's more or less what the labs are reproducing. This is happening at all laboratories, even at Quest, LabCorp. Every laboratory is creating their own LDTs, they call that. And these lab developed tests and LCMS for free and total testosterone is one of those tests that are being tested.
Tell us about the Amino Assay versus Amino Assay.
So the Amino Assay, those tests, for the most part, those are FDA approved, and those are being ran on different machines. Obviously, the LCMS has its machines, and the Amino Assay has its machines, and those tests are FDA approved. However, sometimes the sensitivity of those tests is not as high as a sensitivity with LCMS. So therefore, the gold standard being LCMS for the sensitivity of the test.
But it's not it seems like the better one is not FDA approved, but the other one is. This is fascinating stuff. That's why we did the video. So let's try, for the lay terms, we have these technologies and doctors should know them. So let's talk about two types of patients. One is being diagnosed for low T, including women, men. And then we'll talk about when you're on testosterone, some of the pitfalls. So a man that's diagnosing, or woman, again, because we have more and more women, I don't want to exclude and alienate women, want to make a conscious effort not to do that. But I come from so many years ago, 20 years ago, where it was just men, even men that are regular guys, that are middle-aged guys, if they're not low enough, it's changed. Now it's unbelievable, right? I didn't expect any of this, right? So if you're diagnosing, say, a man, for an example, your age, younger, older, metabolic guy, maybe has been overweight, doesn't feel good, sex drives down, fatigued. It's all non-specific. It's mandatory to look at the gonadotropins, right, the LH and the FSH, right, to localize the lesion or the problem. Is it more in the central nervous system or in the testicles? You have to get that right out of the way, guys. Right. And we don't just do one lab, we do multiple labs, right? We do it in the morning because you want to see the high level, because it dips down with the circadian rhythm, right? There's going to be some circadian rhythm to it. And you want to see the higher level, funny enough, in the morning. And you want to repeat it. Now, can you tell us on your lab, as far as being an expert liaison to healthcare practitioners from a real lab company, can we talk about that from your side more, about this diagnosis?
Well, as a liaison, what I do is I assist with, setting up the accounts and making sure that all the results, and then oftentimes, as this as a doctor, the labs are pending for 2 weeks. What's going on? What happened? which could sometimes be a back order of some of the chemicals that's required for testing.
Wow.
But really, what I always find is that I find the lack of knowledge of when to test. For example, nadir is something which I always find oftentimes having a conversation with these pop-up locations that are doing hormone replacement therapy, and they don't know which tests, or they just say, okay, I just need total testosterone, and they're just diagnosing based on that alone. So oftentimes, you get that in the industry a lot.
Testosterone levels, when you're on testosterone, including estrogen, it's a moving target. So once you're at steady state, which typically with cypionate or enanthate, it takes about 6 to 8 weeks. You're completely at steady state from injection to injection. It could be every week, the injection, once every 7 days. And with most of my patients, it's a small dose, like 0.5 of cypionate at 200 milligrams per mil every 5 days. It's just 0.5 Q5, 0.5 Q5. And then we want to look at that nadir dose, like you said. If the guy goes to the lab 24 hours or 36 or 72 hours after the injection, it's going to be high. And then the doctor is going to say, whoa, you're way too high. Let's lower it. Now, if you're not doctors, nurse practitioners, and people of the audience, if you don't understand the pharmacologic dynamics of injectable testosterone esters, you're out. You're out of the game. I mean, you have to. That's why we're here. So, and that's why we microdose. So if guys don't like those ups, I mean, when a doctor gives an injection of cypionate, 200 milligrams in the office every 2 weeks to a month, which still happens, it's way up and way. When guys come in and they go, doctor, I'm here because my testosterone doctor was treating me for testosterone, and it turned out that my number was 320, and then I dropped down to 180. He lowered my testosterone. Here's what's happening. He's giving 200 milligrams in the body, in the rear end, maybe in the office every 2 weeks or 3 weeks or every month, doesn't let the patient inject, which is wrong. That's wrong. That's wrong. And in my opinion, and then if you let it go after the injection 2-3 weeks, and you look at the nadir, you just shut the guy down, and the medicine you're looking at in the blood, it's low. That's why we need to, in my opinion, inject equal to or less than every 7 days with cypionate, enanthate, propionate, shorter acting. We don't even use much of it, but you could, guys, you can. Sustanon 250, 4 esters, more complicated, but it's still got a similar half-life overall, about 7 to 8 days. Please, bro science guys, don't hang me on the incredible, nitpicking details, but it is true. Okay, very similar. And the undecanate, it's a long-acting ester. It's used in America for injections, and at every 10 weeks, once you're at steady state, every 10 weeks, it's got a long trajectory. It can work for guys, but it's just market's not there for it, because you get this big trajectory, long up, like the pellets, way up and down. Not against stuff, guys. If it works for you, good for you. Most guys use these intermediate acting esters, cypionate and enanthate, equal to or less than 1 week, because it's going. And then when you look at the number at the lab, we do nadir dosing. You know why? It's mainly for the doctor, because the doctor didn't want to see a big number. I swear to you, it's so funny. It's really nadir dosing came out of the doctor doesn't want to see this super physiologic number because he doesn't want to lose his license for giving steroids. I am telling you the truth. So, but if you don't talk to your patient and the patient goes to the lab on day 2, you're going to see a big, and if you want to see your peak, look at your peak. But how do you feel? How's your mood? Are you moody? Are you stressed? Are you anxious? Is your sex drive way up, way down? How about is your sex drive correlating the opposite, which is, hey doc, when it's way, way high, sex drive's down. Then when it lessens in the system, sex drive goes up. Welcome to the real world of clinical medicine. It's not what you think.
And that's why you're testing as a doctor, you're recommending to always test at the same time. I mean, if you want to test every day, I mean, the day after your dose or right after your dose, you can do that. But it's just people are, like you said, they're going to go, other doctors are going to go crazy. I think the pharmacist is going to also look at their labs and is going to say, no, we can't. Why are we prescribing to this patient? His testosterone's through the roof. And I
So
think
first off, pharmacists really don't have the HIPAA right to look at the actual lab. I've been into some pissing matches with some of these. They don't feel comfortable filling the damn thing. They don't feel comfortable filling it. That's a whole nother story. They have a license too. But when you're looking at these numbers on paper, we just learned about the technology. It's very complex. There's a huge standard. Let me ask you this. Is there a standard deviation around the curve that you guys have to, as a reference, evidence-based, to tell doctors like me?
well, I would look at, depending on the lab that you're looking at, look at the ranges. So if you have a patient that went to Quest, and at Quest, let's say the result was 1,000, just use a round number. And then at another lab, the result was 800. That doesn't necessarily mean that the results are off. Look at the range and how much are they off on the range.
Wow.
Is that other lab's range 800? Always look at the range as well. And the same thing goes for free and total. And then for free, if they are not testing for LCMS, see if it's being calculated. If it's calculated, then you know you really can't rely on that free.
Right. Tell us about that. Tell us about that technology, the calculated.
So the calculated is an equation of off the sex binding hormone globulin, and based on that, it'll tell using the total and that number, it'll give you a number of what the free testosterone is, as opposed to with LCMS. And there's also an amino assay that tests directly for free. So just know what you're getting with what your doctor's ordering at the lab.
Right. So this is where, guys, you're not a number on a piece of paper. We use the science, we use the labs. Depending on who you are, does it make sense clinically? I want to be very careful with that, because if you're on too high a dose or too low a dose, you should understand, again, the peak, the trough, based on the ester, based on your genetics for how your enzymes are degrading. I had a guy, I'll never forget this because he's not with me anymore. He's a great dude. Had him for like 5 years. I've been doing this 20 years. And he was not a big guy, funny enough, and he did some steroids and he caused himself to have low T, anabolic steroid-induced hypogonadism. Everything's documented. He was he's an accountant actually, and with a family, and had problems with fertility, and realized that the steroids he did in college and some years after caused fertility issues and caused him to have low normal T. So we worked on that. And then I started him on the usual dose that I start with, 0.5 every 5 days of cypionate, dosed at 200 milligrams per mil. And within months, where he was going the nadir and the numbers were low, 182. I was like, sir, are you playing games with me? Because as a doctor, you're like, this guy's messing with me. He's trying to get steroids out of me. I didn't know the guy at that point. But I was respectful, and we kept going back to the lab. I am not kidding you. We ended up putting this guy on something like, you ready for this? 0.8 milliliters, 160 milligrams of testosterone every 2 to 3 days. And it's not bullshit. It's something I've almost never seen before. And his free was then at nadir every 2 or 3 days. The nadir, right? It was like upper limit normal. Sometimes he'd go a little bit up to the top of the physiologic range. He felt great, and it was unbelievable. His enzymes with his fingerprint, everyone's got a fingerprint. You can't McDonald's medicine this one. But a lot Gaussian curve stuff. The average guy is going to be this. It's average, mean, median, mode all day long. But you have to give personalized care for these people. That's why the testosterone mills, and they're not all mills, they're really going to be the testosteronologists that I'm training and other good facilities are going to be taking all the business, because you just can't give 200 milligrams to everyone twice a week, break it down, and then just boom, 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 boom. You just can't, because most people are going to be way over the top, bloated, hypertensive, forget the side effects and the gynecomastia and all that. It's just not sustainable. But in the same right, what exactly are your testosterone labs? Do you understand the technology? So many healthcare providers, they're going to watch this video and learn.
In that case, with that patient, I would have recommended to you, if you were by me and you said, hey, Shimon, what's going on with this patient? I would have said, let's send him to another lab, test him at another lab. If you're constantly raising his dosage, maybe there's something going on over here. Send it to another lab. Maybe the lab that he's being tested at is just, maybe there's an issue.
But here's the thing. So this is over a year, right? This is over a year, because I'm dialing the guy in, right? This is called, really, dialing someone in accurately, appropriately. You go up, and then how do you feel? He wasn't really feeling it, right? There was nothing dangerous about it. And I was using the same lab. It was Quester LabCorp.
Okay.
And I didn't certainly understand this stuff back then, but it was very consistent, and it was going up on that scale. So I was using an apple to an apple. But you are right. If I had you in my back pocket, it would have been even more confusing, because I would have been all over the board. But I went clinically. You see, I did it clinically. It was going up appropriately. We didn't jump up to that 0.8. We went to 0.5. We went to 0.6. And then we started to bring down from every 5 to every 4 days. You see that? There's a couple of variables. There's the concentration and the type of testosterone. Prop, enanthate, cypionate, sustanon, undecanate. Then there's the amount you put, the concentration, 100 milligrams, 200 milligrams. On the steroid world, underground, there's even testosterone 400, which I've talked to the expert bro science guys and pharmacists. They don't believe you could pack in 400 milligrams of any testosterone ester into a milliliter of any oil. Now, maybe 300. Sustanon 250 is 250. Now, this is the bro science, right? That's why you guys love this, right? But in the end, so you're looking at this huge spectrum of testosterone esters. You have to understand the pharmacology, and it's going to be all over the board. But clinically, how is the guy feeling with his emotions? And we're not doing it for that. I mean, like, guys, I love that. I'm still benching big, and I'm 60 and I'm killing it. But it's like, we're doing it for regular guys and women to bring back wellness and quality of life and be sustainable. If you can live on big doses, you ain't going to be sustainable. What good is the party if it's going to be over? I never want this party to end. All right, Shimon, what else let's wrap up. Tell people anything you want to deliver for yourself from your social media, or any closing words.
Well, I would say as like you are, as for the practitioners out there, always question the labs. If something is off, speak to your representative. That's what we do at our laboratory at Accureference Medical Lab in Linden, New Jersey. That's what I do. I get calls all the time from docs. I have one doctor saying, hey, Shimon, the vitamin A just doesn't make sense. The vitamin C doesn't make sense. I'm not just talking about the basic labs and lipids and the CBCs, but doctors question the labs if something doesn't make sense. Sometimes something doesn't make sense because a doctor might miss something lifestyle. I'll just say, like, a quick story is that there was a patient, their mercury levels were through the roof, and the doc couldn't believe how high they were. Turns out the patient was having 2 cans of tuna every single day, hence their mercury levels through the roof. So question every single thing, question the laboratory, and if something doesn't make sense, and retest, and I would even say retest sometimes at another laboratory to, just to make sure that all the I's are dotted and the T's are crossed.
How can people get a hold of you, Shimon?
You could find me on LinkedIn, Shimon Lobel at LinkedIn, or you could go to Accureference.com, and you could reach out to us through our website, and you can reach out to me through the website as well. And I could set you guys up, set your office up. If you're in the United States, we could set your office up with testing via our laboratory, whether it's insurance or cash-based, depending on your population.
Thank you, Shimon. This is super cool. Guys, give a lot of cool comments. Have you experienced this? Numbers all over the board. Does your doctor know what's going on? Do you guys understand this? And so much more. Thank you so much, everyone.